we'll have Dr. Tutton join us, like I said, from a video. He's an interventional radiologist and professor of radiology and surgery at UCSD. Since receiving his medical degree from Rutgers New Jersey Medical School and completing his IRN training at the McGaw Medical Center at Northwestern, Dr. Tutton has been practicing for over 26 years. He serves as the educational advisor and one of the founding members of the Society of Interventional Oncology. His clinical focus includes hospice and palliative medicine, as well as experience in interventional oncology, bone metastasis, bone fractures, and cancer therapies.
Okay.
Good morning, everybody. Sean Tutton from UCSD Health. I want to thank the organizers for inviting me to participate. We're going to talk about palliative interventional radiology. We're going to touch on the pillars of cancer care, the traditional ones being medical oncology, surgical oncology, and radiation oncology. And we believe that interventional oncology or interventional radiology is the fourth pillar. And I've sort of coined this the fourth pillar cancer killers. So I'm actually also board certified in palliative and hospice medicine. And one of their mantras is to cure sometimes, to relieve often, to comfort always. And this is considered their work. They strive to relieve symptoms and distress, help patients better understand their disease and diagnosis, help clarify treatment goals and options. And they understand and support the patient's ability to cope with their illness, assist with making medical decisions, and coordinate with other doctors. And that's sort of the mantra of palliative care. I would maintain that that should be the mantra of all physicians. And as a palliative interventionalist, I make the pledge that I will help patients relieve their symptoms and distress, help them better understand their disease, clarify their treatment goals and options, understand and support their ability to cope with illness, assist them with making medical decisions, coordinate with other doctors. And above all, we have a lot of interventional therapies, which we call palliative interventions, that can improve their quality of life. So palliative IR practice is a relatively new concept. It's one that a number of us have created within interventional radiology. You're typically a member of a multidisciplinary team called on to address complex pain patients, spine mets. But remember, there are a number of tools that we have in our toolbox as interventionalists. We can biopsy to facilitate the diagnosis. We can provide central venous access. We can do anesthetic blocks and neurolysis, ablation of tumors and metastases, as well as provide structural improvement with augmentation, bone osteoplasty and fixation, which I'll touch on later, embolization for pain and or bleeding, decompression of obstructed organs and abscesses. But above all else, we participate in the patient's care team, and we identify those procedures that the patients will truly benefit from. And I think you need to be their advocate, right? And one of the sayings we have is always goals before holes. Be that palliative interventional radiologist. Patients continue to suffer with pain. Most patients with advanced cancer experience significant pain, 60% of which of those patients that have chronic diseases will have some pain. And sadly, 25% of patients with cancer die in pain, according to the WHO. And there are a number of different types of pain that we need to address in order to really appropriately care for patients. So their physical pain, their existential pain, that, pain patients experience because they're afraid of dying and they have unfinished business or they're just not ready to die. Somatic versus visceral pain, tumor-induced pain, mechanical pain, and neuropathic pain. So breaking it down further, you have nociceptive pain, which it results or is a result of damage to tissue. This pain tends to be somatic, sharp, well localized. It's the sharp pain of a laceration. It's the sharp pain of a fracture. You have visceral pain, which is more dull, achy, a little bit more difficult to localize. And this is typically driven through the autonomic plexus. You have neuropathic pain resulting from damage to nerves or infiltration of nerves. And you have pain or throbbing or electrical type discomfort, depending on where the pain, neuropathic pain. And so we have multimodality ways of treating this pain, and interventional therapies can really help reduce the pain as well as narcotic needs and improve patients' quality of life. And so as an interventional radiologist, we have a major advantage in that we have the image guidance. So image-guided blocks and neurolysis, the ablations of bone and soft tissue tumors, vertebroplasty, sacroplasty, osteoplasty, the hybrid MSK procedures that I do, embolization for bleeding and tumors, and then these decompression drainage procedures. The NCCN guidelines you should become familiar with. They are the sort of the gospel and how we deliver cancer care. And there's one that is very specific to adult cancer pain, and we are in it. We are in the nerve blocks, vertebral augmentation, ablation paragraph there that you can see after the medications have failed or in an effort to reduce those medications. We also are now participating in the fixation and stabilization when it comes to vertebroplasty or some of the structural work that we do in the pelvis. And so you can see that our book of business and the things that we have to offer is pretty broad, right? So we can do neurolysis using a needle and an anesthetic, and in some cases alcohol under CT or ultrasound guidance. We can ablate nerves in patients that have painful nerve symptoms. We can do bone or tumor ablation using either heat or cold-based ablation therapies. We have vertebral augmentation or fracture repair. And most recently, we've started to do hybrid procedures where we couple ablation, cement augmentation or osteoplasty, and then also the placement of screws for mechanical pain in and around the pelvis. But the basics are the nerve blocks and neurolyses. So the most common one that we offer is the celiac plexus block. This is one for patients that have epigastric pain, most commonly in the setting of pancreatic cancer or other epigastric and upper abdominal cancers. We target the plexus around the celiac artery, and we block it with an anesthetic, thus blocking the sympathetics and allowing unopposed parasympathetic stimulation. This decreases pain, decreases nausea and vomiting, often will improve constipation and gastric motility. And this is a patient where we use navigation and CT guidance to inject some contrast, and then an anesthetic, and then finally alcohol to destroy the nerve tissue in that region. We can also decompress blocked biliary structures, and so this is a CT scan showing dilated bile ducts that are obstructed, and so we can do a percutaneous biliary drainage to decompress those bile ducts, relieving pain and improving the patient's liver function. We can decompress the stomach with a simple gastrostomy tube, and both of these are examples of visceral pain, that achy, sort of deep pain that can be very difficult, keeps patients up at night. Obviously, the nausea and vomiting that goes along with it. With ascites, either related to malignant ascites or non-malignant cirrhotic-related ascites, we have a number of different things that we can do. And so we can offer medical management, but we can also do drainage procedures. And so we can perform an abdominal tunnel drainage procedure called a peritoneal drain, or we can use a pump that drains the ascites back into the circulation. And so this is the peritoneal tunnel drainage catheter, and you can see it here in the abdomen. And this was randomized against multiple repeated paracenteses, which is where we take a needle in and drain the fluid. And this ended up being much better for the patients with similar complication rates. Here you can see somebody with a tremendous amount of ascites, and this patient had what's called the TIPS procedure, where we can actually decompress the obstruction in the liver and the buildup of portal hypertension by placing a stent from the portal vein to the hepatic veins, thus decreasing the pressure. And that's another method of decreasing the ascites. And then this is the Denver shunt. This is just for demonstration purposes, but this pumps the fluid from the abdomen and puts it back into the circulation. Switching over to things like critical limb ischemia, we can offer angioplasty, stenting, atherectomy to open up blocked vessels. But occasionally we cannot offer those things, and so we can actually offer another nerve block, which is called a lumbar sympathetic block, where we block the nerves in the paralumbar region, and those actually are the autonomic nerves, again, that deal with vascular tone and promote vasodilatation when you block them, and you can see the hyperemic response in this vascular path's foot after we block them, and you can see how red that is after we block that patient. We can unblock large venous structures, and so this is the superior vena cava that's obstructed before it can get back into the atrium, and you can see all the collaterals in this particular situation. We get across, we do angioplasty, and we put a stent in, and thus massively decompressing the obstruction, relieving the patient's symptoms. We can stop bleeding, and so this is a bleeding iliac vessel where we did stenting, stopping the bleeding and saving the patient's life. Finally, we can address musculoskeletal pain, and so here's a tumor in the ischium. We can do ablation and then put cement in there, or if there are significant fractures, we can do combinations of cement and screws, usually in conjunction with our ortho colleagues. We have a whole host of ablation technology that we can use to treat bone and soft tissue tumors, and here are a multitude of studies that really show benefit in both the radiofrequency ablation, cryoablation, and microwave space. And here's a patient with a vertebral MET that's hot on PET, access, ablation, and augmentation or vertebroplasty with significant improvement. And finally, we've published on the combination of cement and screws to address these structural and mechanical problems in the pelvis. And so this is transsacral screws that were placed percutaneously that we've published on in a number of different venues, improving patients' mechanical pain in the pelvis. And here's another patient again, ablation, screw, and cement augmentation to address a large defect in the acetabular region. And so in conclusion, to build a successful palliative IR practice and to understand it, you need to become a member of the team, a multidisciplinary team. You need to be willing to tackle some of these complex pain patients and spine METS patients. We're cancer symptom specialists, and we seek to become the fourth pillar of cancer care in the cancer centers, in large academic centers. We have a large number of procedures that we can offer as a palliative interventional radiologist. And so I encourage you to consider this as a really bright area of growth in our field of interventional radiology. Thank you for your attention. I'm sorry I ran a little bit long, and I'm sorry I couldn't join you guys in person, but enjoy the rest of your meeting.